This video presents the technique of anatomical restoration of the LFC shape after an impaction fracture associated with ACL rupture with the use of a patient-specific implants. The MRI scan in sagittal plane shows lateral femoral condyle impaction fracture with evident loss of congruity in the lateral compartment of the knee. The MRI findings are confirmed under the arthroscopic visualization. The LFC impaction fracture site has the depth of about 6 mm as measured by arthroscopic probe. A 3-4 cm longitudinal skin incision is made over the LFC, enlarging the anterolateral arthroscopic portal. The LFC IF is shown with the tweezers. Firstly, the periosteum is cut parallelly to the chondral border about 3-4 mm proximally from periosteochondral junction and mobilized. The first template serves as a naming device, designed to fit into the LFC IF. If the LFC IF is wide and shallow, the PSI is elongated to one side and its accuracy relies on the surrounding condylar surfaces. For deep fractures, the template's body is equipped in a bump adequate to the deepest part of the fracture. After the first template is adequately positioned, two 2 mm K-wires are placed to serve as a guide during the further procedure. The first template is removed and the second and third templates are used to perform the osteotomy pre-drilling parallelly to the fracture. The drill tunnels interfere to create an even shape of the osteotomy. The depth of the drill canal is planned during creation of the templates. The osteotomy site is finished manually with a 6 to 8 mm osteotome by handheld maneuvers. Then the osteochondral flap is mobilized with the blunt elevator using the surgeon's finger for cartilage assecuration. Next, the fourth template is inserted onto the guide K-wires. It limits the elevation of LFC depression, preventing the fracture of osteochondral flap. The fourth template recreates the native shape of LFC during bone grafting. The restoration of curvature with the fourth template guidance can be seen on the video. It aids the surgeon to insert the right volume of bone graft and safely restore the native curvature of the LFC. The bone cavity under the osteochondral flap is shown before and after filling with bone grafts. The periosteum is sutured and wound is closed. Afterwards, the lateral compartment congruency can be assessed by arthroscopic visualization in flexion and extension. The sutures of osteochondral junction are visualized and inspected for any bone grafts leakage. The MRI follow-up at 6 months show proper lateral compartment congruency with bone graft remodeling.